Hi, everyone. Welcome to today's seminar on reimagining a sustainable healthcare safety net. I am Rachel Werner. I'm the Executive Director of Penn's Leonard Davis Institute of Health Economics. Safety net providers fill a critical role in our communities with a mission to care for all people, including uninsured, low-income patients, and other underrepresented and marginalized groups. Safety net providers are the providers of choice for people and communities who often have poor access to care otherwise due to social and financial barriers. Safety net hospitals provide the majority of safety net care, and they serve the nation's most disadvantaged communities, where 22.3 million people live below the poverty level and more than 14 million people are uninsured. And they've also proven to be the front lines of the public health emergencies in this country, including during the ongoing COVID-19 pandemic. Concerns about sustaining the healthcare safety net are not new. In 2000, the Institute of Medicine released a report called America's Healthcare Safety Net, Intact but Endangered. In preparing for today's conversation, I went back and read parts of this report and was struck by how little has changed since 2000. The report says America's healthcare safety net is a patchwork of providers, funding, and programs tenuously held together by the power of demonstrated need, community support, and political acumen. The safety net has never been particularly safe or secure, but changes in the current healthcare system in combination with rising numbers of uninsured may be placing the nation's healthcare safety net at new levels of risk. So perhaps today the motivation for our concerns has shifted. And in place of worrying about rising numbers of uninsured, we have a new set of issues that affect the safety net, including uncertain and declining funding, financial strain potentially from the COVID-19 pandemic, and an acute recognition of the chronic problem of crumbling public health infrastructure. So it seems we're really in a similar situation today with our healthcare safety net. It's intact, but still endangered. And that the case that the IOM report made more than 2 decades ago for investment to support a sustainable safety net seems just as strong today as it was in 2000. Today's conversation will focus on how we can reimagine and sustain today's safety net so that it can fulfill its mission of caring for all people. We're lucky to have a terrific panel of experts who spend much of their time thinking about just that. So first we have Paula Chatterjee. Paula is a senior fellow here at LDI and is an assistant professor at Penn's Perelman School of Medicine. Her research focuses on financing of the healthcare safety net, particularly in hospitals, and the effects on the care for low-income patients. She is also an attending physician at the Penn Presbyterian Medical Center. Dave Chokshi is the 43rd commissioner at the New York City Department of Health and Mental Hygiene during the COVID-19 pandemic and was the inaugural chief population health officer at NYC Health and Hospitals, which is the largest safety net system in the nation. He is currently a clinical professor of medicine and population health at NYU and a practicing physician at Bellevue Hospital. Carla Denise Edwards was senior vice president and chief strategy officer for the Henry Ford Health System, where she provided executive counsel and leadership for the system's strategic planning efforts, partnership ventures, and other initiatives. She now works as a consultant and a strategic advisor. And last but not least, Dora Hughes is the chief medical officer at the Center for Medicare and Medicaid Innovation. She leads CMMI's work on health equity, provides clinical and policy advice on model development, and liaises with the Innovation Center's stakeholder community. So welcome everyone. Thanks so much for joining us today. Paula, I wanted to start with you and tap into your expertise about safety net hospitals. And I wondered if you could start by giving us a little more of a lay of the land than I did in my introductory remarks, and tell us a little bit what role hospitals play in America's safety net, and what kind of care they provide, the quality and financial status of these hospitals.
Sure, absolutely. So first, I just want to say thank you so much to you, Rachel, and to LDI for hosting this conversation today. I'm really excited to learn from all the panelists and be a part of this discussion. In terms of defining the healthcare safety net in the US, it's probably a more complicated answer than you might hope. I think an important place to start is with the fact that healthcare for low-income patients in the US is heavily concentrated, meaning that about 80% of the healthcare that's provided to these patients is actually delivered by somewhere between 20 to 30% of clinicians in healthcare facilities. And that concentration of care is actually evident across the continuum of care, right? It's present in the outpatient setting, inpatient setting, and to some extent in the post-acute care setting. Safety net hospitals, which I spend my time thinking most about, are part of that larger continuum. They are the hospitals that disproportionately serve low-income patients, and they are often the only source of care that's available for patients who might otherwise have challenges paying for it. And that might be because those patients are uninsured, they're underinsured, or otherwise unable to assume cost sharing because of their economic circumstances. And so in serving these patients, safety net hospitals provide this essential mission in the US healthcare system, but they typically operate under pretty thin financial margins because a lot of the care that they provide goes uncompensated. What's interesting about safety net hospitals as a group is that there's actually no universally accepted definition for who they are. In some ways, a safety net hospital when you see it, right? It's NYC Health and Hospitals. It's the Henry Ford Health System. It's Parkland in Texas, LA County in California, Cook County in Chicago. Like, it when you see it. But because the function of those hospitals can differ so much depending on where you are, formally defining them is actually a pretty, impressive policy challenge. One of the ways that this challenge manifests is across geography, right? Safety net hospitals in urban areas can look very different from those in rural areas. Urban safety net hospitals tend to be these large nonprofit or government-owned institutions that provide a teaching service in educating the next generation of the healthcare workforce. And they provide a lot of care for services that are often essential for low-income patients, but are often very unprofitable. That includes things like trauma care, obstetric and neonatal intensive care, inpatient psychiatric care. These are resource-intensive services for which the burden of disease that's associated with those services is disproportionately high among low-income patients. And so you get that combination, and that presents another host of financial challenges for these hospitals. In rural areas, safety net hospitals can look a little different in terms of their size, but the challenges in many ways are the same. I would say that in general, safety net hospitals are seen as these trusted healthcare institutions by their communities because they're often the only door that's open for patients to engage with their healthcare. So I'll stop there.
Okay, so before I let you completely stop, I wanted to just follow up. So you talked about how it's hard to define what a safety net hospital is, when you see it. And yet it's really essential to define it well because money follows those definitions. And so can you tell us a little bit about the challenges how policymakers have thought about defining safety nets, the challenges that causes, and your thoughts on that?
Definitely. So in the absence of, some universally accepted definition, there are completely these working definitions for safety net hospitals. So I'm just going to pick one of them to talk about. One of the most common working definitions for whether a hospital is a safety net or not is whether that hospital serves a high proportion of patients insured by the Medicaid program, or whether that hospital serves a high proportion of low-income older adults who are enrolled in Medicare. So Medicaid, service to Medicaid patients and service to low-income older adults. The more a hospital takes care of one of those two groups of patients or both, the more they are able to access a variety of different pools of federal funding to support that care. What's great about this definition is that it's easily measured, right? We collect these data, they are utilization-based, we can follow them in claims, and that is a definite advantage. What's tricky about this definition is that it does codify some geographic biases. So what do I mean by that? The definition incorporates the share of care that is provided to patients insured by the Medicaid program. But Medicaid differs across all states in terms of its generosity. And so if you're a hospital that's in a state where Medicaid coverage is less generous, then low-income patients might not be covered by Medicaid despite their need. And so the local safety net hospital is still going to take care of those patients, right? No matter what. But from a funding standpoint, all that's appreciated is that, that hospital doesn't serve a lot of Medicaid patients. And then I guess the question is, do we think that those types of potential geographic biases have consequences? And I think we have some data to tell us that they do. For example, after the Affordable Care Act expanded Medicaid, what we know is that safety net hospitals were able to pull down some additional funding. One was from the fact that they have newly insured patients. That's a great thing. The other place that they could pull down funding is that now they have more Medicaid patients, right? And that can get measured and appreciated and then allocated and then funding can get allocated indexed to that measure. That's great and all, unless you're a hospital in a non-expansion state, right? What we know is that the research has shown us that hospitals in non-expansion states have actually been at greater risk for closure, partially due to some of these financial challenges in the post-ACA era. And so I think that, this working definition has definite advantages. It's measurable, it's generalizable in a lot of ways. There are some of these limitations related to geography, also limitations related to the fact that it's utilization based. And I can talk about that a little bit later and the potential biases that presents. But that's sort of one of the most common definitions that we have to try and figure out who these hospitals are.
Okay. Thank you. That was a great overview. Dora, I want to turn to you next. So improving payment to safety net providers is one way to try and improve the safety net system. Your work at CMMI has been in part to develop and test innovative payment models. And last year, CMMI released a strategic refresh that included the goal of advancing health equity through alternative payment models, in part by increasing participation of safety net providers in those models. I wonder if you could tell us a little bit about why CMMI views that important, and more specifically, what we worry about related to equity and these value-based payment models or alternative payment models.
Sure, and also I too want to thank you for inviting me to participate today. This is such an important conversation and increasingly a prioritized area of focus for the CMS Innovation Center, as you've noted. For those of you that are less familiar with the CMS Innovation Center, we were created as part of the Affordable Care Act to test models that would improve the quality of care and reduce the cost of care for the beneficiaries that we serve. And then around 2020, 2021, after our first 10 years, it made sense to take a step back and think about what have we learned from the first 10 years that would inform our next 10-year, our 2030 goals, if you will. And as one of the many lessons that we learned is that in our first 10 years, we didn't focus on equity enough. We don't know the impact of our models on equity. And importantly, we didn't do a good enough job of serving beneficiaries who are low income, beneficiaries of color, other underserved populations. And so that really helped to contribute to our vision for 2030. We're a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And within that, there are 5 pillars. Equity is one of them, as you noted. And we want to make sure that we are serving through our models the full diversity of beneficiaries in the Medicare and Medicaid programs. And a key to that strategy, we think, is increasing the number of safety net providers, because as Paula pointed out, as many of you already know, that safety net providers take care of a disproportionate number of lower income populations, populations of color, other underserved populations. And so that by more deliberately partnering with safety net providers, bringing them into our models, that we will be able to have access to this really critical population of focus for our center. And it's also not even just about the numbers, as important as that is, but also safety net providers that have a long track record in terms of having the trusted relationships in the communities, having a major footprint in many areas where the other providers are not located. They already have expertise in thinking about how do we provide culturally and linguistically appropriate care. Who's on our care team working with community health workers, as example? How do we screen and address social needs that many underserved populations are more likely to experience? At the end of the day, just many safety net providers that just provide higher quality care and are able to achieve better outcomes and better access. Again, just because this is what they do or this is what they've always done. And so for us, it's just been a really critical part of our thinking moving forward. How do we include more safety net providers in our work?
And so, one of the concerns related to alternative payment models and providers like safety net providers is that they don't have the finances needed to invest in really improving quality, and therefore aren't going to be able to achieve the high level of quality that will enable them to get the financial incentives. And so they may actually be penalized, and it may end up worse off than if they didn't participate. How is CMMI thinking about that, and what kinds of programs have you put in place to try and address that?
It's such an important point, and one that we have heard in Technicolor, as you might imagine, from the safety net providers and organizations that represent them. And so a number of different ways. On the front end, as we're trying to recruit and attract and retain safety net providers, we know that for some of our models, we're going to have to design them differently. Maybe we will provide more of an upfront payment to support investments in infrastructure so they can bring on the data systems, retrain providers, or whatever the case may be. Perhaps we have to provide this funding upfront as opposed to throughout the model. In some cases, there may need to be considerations of how much risk that we would require safety net participants to take on. As Paula noted, there's such thin margins for safety net providers that the notion of taking a 3% or 5% downwards risk is just not one that safety net providers can entertain. So just again, being really thoughtful, even thinking about our application process. Some of those applications could be hundreds of pages. And so what type of TA and technical support to even get through the application process to join our models? But that would even and one more I would mention, just in terms of the resources, from our recent models that we introduced even this summer, you will see that we have started thinking through social risk adjustment. How do we risk adjust the benchmarks, for example? How do we provide increased resources for those providers that are taking care of a disproportionate number of underserved populations? We saw that as for our newest oncology model that was just announced in July of this year. There is an enhanced per member per month payment on top of the base payment. Again, for providers that are taking care of a number of disproportionate beneficiaries who are dually eligible for Medicare and Medicaid. So thinking about the resources, the level of resources, the structured resources, wrapping around the technical assistance, all of that is part of, we're certainly laser focused in thinking about how can we make it right, not only to attract safety net providers, but making sure that they're successful in our models.
And has there been, how has the progress been in enrolling safety net providers into the models to date?
So you know all the pain points here. The short answer, we don't know, but there is a better answer in the sense that a year ago when we released our vision, our strategy refresh, we noted that we wanted to include more safety net providers in our models. This year, just about 3 weeks ago, we released a one-year update. And as part of this update, we have included measures that we will hold ourselves accountable to moving forward. And one of those metrics is how many safety net providers in our models, how many safety net facilities are represented in our models. We have baseline data that we present in this report and our targets for the next 10 years. And so every year or so, we will be able to report back and hopefully have a better answer to that question in terms of how are we doing.
Okay, so we'll follow up next year about that one.
Yes, this time next year.
Yeah. All right, thank you. So I want to turn the conversation a little bit to the role of safety net providers in the public health infrastructure. And Carla Denise, I want to turn to you next. So reimagining the safety net may require us to move beyond just improving finances of safety net providers, which we've been talking about so far. The COVID-19 pandemic certainly highlighted that there's an important role that safety net plays in public health. As providers really became the principal source of treatment for COVID-19 and also immunization for many people during the public health crisis. So in this context, I've heard you say in prior conversations that we've had that we have an opportunity to reimagine the safety net to be more expansive. Can you tell us what your view of that expanded safety net is?
You know, it's interesting as I've been listening to my colleagues who are very well versed in this topic, how we're focused on the safety net. And there are formal definitions of safety net, and as Paula mentioned, very informal definitions of safety net, because there are many providers who may not fit the formal definition, but who are actually doing the work. I think a critical question, Rachel, is not just what we need to do to reimagine our safety net, I think we need to reimagine the public health infrastructure. If we only focus on providing resources and filling the gaps for those who are underserved and underrepresented from a financial or economic standpoint, we risk the spread and the proliferation of disease among others who may be well-resourced, but still can't access the system. So having insurance or having coverage doesn't necessarily mean you have access to a high quality provider, a provider in your community or neighborhood, right? And that has time for appointment. Nor does it mean just being insured or covered by Medicare or Medicaid that you actually have an appreciation for the need to be treated or to be seen. I strongly believe that those who have been disenfranchised deserve to have access through coverage. But I also believe that everybody needs to be able to access a public health infrastructure that promotes health and prevents disease. And so one of the things I think that COVID taught us is that whether you're insured or not, you are susceptible, right, to a global pandemic. What we also learned is that people who were uninsured, underinsured, right, as well as those who live in circumstances with very poor social and economic determinants of health are more at risk of dying from disease and dying from COVID. And so when I think about reimagining the safety net, Rachel, what I really am thinking about and in my conversations is reimagining how do we have an infrastructure for protecting the health and the well-being of the larger and general community, i.e. the public, insured or not insured. One of the things that will make those safety net hospitals that Paula spoke about much more viable is if they're not exclusively serving people who are uncompensated or undercompensated, because there's not enough money to support the high cost of that facility. If we're able to ensure that there is enough funding, whether it's reimbursement, and I liked what Dora said, upfront payments, to ensure that that infrastructure exists, then we're able then to ensure everyone, regardless of their payment, is able to access the care that's needed. I like to think about it in terms of the fire department or fire station. And one of my biggest fears is that, doctors like Dave are standing on the corner with a boot collecting money to keep the hospital open, the way the firemen are standing on the corner with the boot trying to keep the fire station open. Everybody wants a fire station in their neighborhood, but nobody wants to pay for it. Could you imagine if the firemen said, we're only going to those people's houses because we actually know they personally and privately paid, taxes, and we're not going to go to those people's house because they rent their house or they're in a subsidized house and we're not going to protect it, right? And so at some point, this reimagination, Rachel, I think needs to not only take into account the fact that our safety net hospitals and safety net providers need upfront payment, need risk adjustment, need enhanced payments for services they provide, but we also need to have the infrastructure for ensuring that everyone, regardless of their ability to pay, can access healthcare resources that keep all of us healthy and well and enables us to prevent the spread of disease. I think that's what I learned from COVID, is that being insured does not preclude you, does not prevent you from getting COVID and dying from COVID. Having access to healthy resources, foods, and environments that protect you physiologically can reduce the likelihood that you will catch the disease and die from it. And so that public health infrastructure, to me, is equitably as important as enhancing the safety net infrastructure.
Yeah. Well, I want to return to the topic of the public health infrastructure and how to integrate it better with the safety net. Before I do that, Dave, I want turn to you and bring up a question about the role safety net providers play in the larger healthcare landscape. And this is actually related to something Carla Denise commented on, which is that safety net care is often very siloed and provided by a very small number of providers. Paula talked about the concentration, both Paula and Dora, the concentration of care within a relatively small number of providers. But these providers really play a vitally important role, not only in providing care to those patients, but also in making it easier for other providers in those communities to provide care. So tell us a little bit about what your thoughts are about the role that safety net providers play in a more of a market of healthcare industry.
Thanks so much, Rachel. And I just want to add my kudos to LDI and to you for having this really important conversation. I'm grateful to be a part of it. With respect to your question, we talk about the way in which safety net providers offer financial protection to low-income patients. You know, that makes sense to us. That's a key part of their role. But we talk less about the ways in which they provide financial protection to many other actors in the healthcare ecosystem, particularly, other providers who are not considered part of the safety net. And I won't mince words. This is an effective subsidy for those other providers. And when we're looking at, part of the ecosystem like nonprofit hospitals, we have to keep in mind that this is an effective subsidy on top of the subsidy that nonprofit hospitals receive by virtue of their tax exemption as well. And the evidence, bears out this point. When we look at safety net hospital closures over decades, the evidence suggests that uncompensated care almost totally shifts anytime that there is that type of closure. What that means is that, there's that spillover effect in terms of where that uncompensated care has to go. And so we have to keep that in mind for the safety net providers that exist today, that they are, the ones who are providing that financial protection to other parts of the system. So, my colleagues, particularly in Carla Denise's comments, have already alluded to some of the other ways in which it's not just about financial protection, but the public functions, that safety net systems provide. We saw this, throughout the pandemic. Certainly we did here in New York City with respect to the way that the safety net systems, stepped up for COVID testing and the vaccination infrastructure as well. But, there's another piece of that also, I think, helps to point a way forward as well, which is we talked about in New York City load balancing. So, when we came under extreme duress in our healthcare system in that really devastating first wave, safety net hospitals, places like Bellevue Hospital, which is where I am right now, bore, so much of the brunt of the care that had to be delivered. And we saw some, but I will say not all, private hospitals step up and say, we're willing to take some of the patients because it was the Bellevues and the Elmhursts that were being deluged, particularly our intensive care units, with COVID patients. And so we called that load balancing. It made sense for us to spread that need around to where there was actually capacity to meet that need. And so one of the ways that I think about where we have to go, the path that we have to forge ahead together, is to think about new kinds of load balancing and recognize the ways in which safety net systems have always and already, bear different types of loads today, particularly with respect to uncompensated care, as we've talked about, but also those public functions, the support of public health that happens every day, not just during a pandemic, as well as we haven't yet talked about, explicitly, but as well as the ways in which racial equity and the ways in which racial inequities, play out in our communities is something else that we have to think about spreading where there's actually greater capacity to redress some of those inequities.
Great. Any follow-up comments before I move on? There's a lot there.
I would just jump in and say that just sort of echoing one of Dave's points about this load balancing, these types of arrangements have been demonstrated in many different parts of the country. So if you look at Massachusetts, for example, before Romney Care kicked in, there was sort of a financial load balancing informal agreement, formalized in some ways, but an agreement between, a market of hospitals, sort of in acknowledgement of the fact that, a lot of the uncompensated care is concentrated at one place. And that does a world of good for the entire market. And so in response to that, they found something, they created something called a free care pool. All the hospitals in the market contribute to the free care pool, and whoever's providing the most free care gets to pull the most out of it. And those kinds of arrangements dissolved after expansion of insurance in Massachusetts, which led to other challenges. But all of that is just to say that I think these load balancing agreements have been trialed in markets and might have some data to guide us.
Related to that, and actually one of the questions is related to payment rates for Medicaid, I believe. And there's certainly evidence that there are many primary care physicians or other providers who do not accept patients insured by Medicaid. This results often in the concentration of care for patients with Medicaid, along with patients who are uninsured in safety net providers. How much of the solution to rebalancing or load balancing is to equalize payment rates and think about really addressing the Medicaid insurance as part of this?
This is Carla. Denise, I'll kind of piggyback on that because I think Dave and Paula made a good point. And what those systems were called were the indigent care pools. And many states created the indigent care pools to ensure that there was a pot of money available for the hospitals that were seeing the preponderance of uncompensated care, regardless of their federal designation. And so I do think that there is a need, or let's say an opportunity, Rachel, for us to find ways to ensure that those who are on Medicaid have access to providers, right? And then those providers are compensated in a way that is sustainable for their practice or for the hospital or for the group. It is difficult to find providers who are willing to take Medicaid because the majority of instances, the Medicaid reimbursement is lower than the cost. However, I would say this, I don't think the providers, particularly the larger health systems, should be off the hook for ensuring that we can manage cost appropriately, which is what Dora spoke of with the innovation projects, trying to incent new ways, right, of financing care, funding care, and then sharing in the savings that occurs so that we can reinvest in innovation and technology in those systems. But I do think we need to reimagine at a community level, a regional level, how to ensure there is enough resources available so that those who actually are insured by Medicaid can have access to providers. The entire community benefits when that happens. And Dave spoke to that very eloquently. I won't repeat it, right? If those providers went away, the patients still exist. And every hospital, regardless if it's private, public, for profit or not, is obligated to treat people who show up to its front door. And so it's in everyone's best interest that there is a front door that promotes health and enables access when people need care. And so I do think we could really think strategically at the community level, how do we have a community level system that ensures there's access for those who are uninsured, and I call Medicaid underinsured, and for those who actually have coverage.
Thanks.
Yeah, I'll just chime in briefly to add a bit on this, which I think is a critical question. You know, the differential in reimbursement rates has has stark consequences and creates the problems in the delivery system that we've gone through. And I'll just say, the way in which that happens creates all the Byzantine workarounds that we see in our system. The indigent care pools are one example of it, but DSH, the disproportionate share hospital payments are another example of it. And really, they're all to try to redress, the fact that you don't have enough money, going for the care of certain patients. And so if you wanted to really solve the root of the problem, you would fix that. One, sort of policy approach that we haven't talked as much about is global budgeting, as a way to get at that. And obviously Maryland has been a pioneer, but I know there are ongoing conversations, in many other places, and Dora can let us know, in terms of how much at CMS as well. But that is one way to actually, try to change reimbursement rates to get to greater parity so that we don't, have to rely on those workarounds. With that said, and like this is a big caveat that I want to give to this comment, I don't think that, I think we'll have to have those workarounds at least for the near term. And they, are arguably the thing that needs to happen right now is that they are strengthened. For example, I talked about DSH and the ways in which, DSH could be reformed so that it's better targeted to, providers that are sort of truly, part of the safety net, rather than how it's spread around to all providers. And particularly, to do so in a way that supports not just hospital care, but the whole person care that Carla, Denise, and others have talked about.
I just wanted to jump in, Rachel, quickly. Dave, I think California did some really good work on reimagining DSH several years ago. And similar to the work that CMMI did, challenged the institutions to come up with ways in which to reduce their total cost, share in that savings, and then enable the savings to be used to adopt technology. Right? One of the challenges with these shared savings programs is the shared savings program causes you to reduce how much you make and then take half of that and then try to do something innovative with it. And you didn't have enough money in the first place. Right. And so it kind of seems like kind of funny to say, okay, I'm going to reduce how much money I make, and then I'm going to take half of what I saved and then use it when I could have had 100% of the revenue in the first place. There has to be something in this reimagination that gets us to a foundational level, right, of sustainability, because it's in the general public's best interest, right, that these institutions exist, to the point that you made around the load balancing.
Mm-hmm. Dora, do you want to weigh in?
Yeah, I was trying to scribble a few notes because there's been so many important points that I would love to talk more on. I wish we had more time, but I even think starting from where the very beginning of the conversation and Paula's discussion of trying to define safety net providers, it made me flash back a year ago when across CMS we thought, well, we should have a unified definition of a safety net provider. And I think there was about 56 people on the Zoom, and right around when someone presented the 11th definition that they had found in a peer-reviewed journal, I knew we would be leaving without that consensus that day, and how difficult it's been. And so I think, but that's a key point for us and safety net providers. It's easy for us to figure out who's the FQHC or who's a rural health clinic. I mean, there's tags in the system for that. But then when you think about safety net hospitals, safety net providers, we too are trying to use proxies. What percentage of patients that you're taking care of that are dual eligibles, or what percentage are receiving or eligible for low-income subsidies? I mean, it becomes a pretty hairy and inexact exercise pretty quickly. And for us, that's certainly more of what we hope to continue to learn. Do we get it right? Are we using, what are the refinements? What's happening in the broader ecosystem that can inform our work? So that's one. The second issue I wanted to talk about, the capitated payments, certainly we think are absolutely critical for all the reasons that we've discussed here for our alternative payment models. But we want to make sure that we're not disincentivizing providers for taking care of beneficiaries who are more costly because they have more medical or social conditions. And so just being really thoughtful about how do we protect the access for these beneficiaries? How do we provide resources that are more directly tied to the beneficiaries? Trying to understand what are providers doing with these additional resources. These are all also pretty tough questions, but we're very much attacking on a parallel track, even as we're continuing on with the capitated payments. And the third mention that I'll make is that we have released internally our strategy in terms of thinking about multi-payer alignment. And that's also really important for our alternative payment models and for our providers. If I'm a provider and only 10% of my patients are Medicare and 50% are Medicaid and the rest are commercial, I'm much more likely to join a value-based care arrangement if my Medicaid agency and the Medicare, the quality measures, the payments, if the commercial, if we're all rowing in the same direction, so that I don't have to think about I have to do this for 10% of my patients, might not be worth my while. But if I even get to like 50%, 80% of the requirements across the payers being at least directionally aligned, if not the same, then it makes much easier, especially for safety net providers to join these type of arrangements and do more in this area. So those are at least three. I could go on, but I'll stop and turn it back to you. It's been really helpful hearing the comments from all of you in terms of messages I need to take back to my colleagues at CMMI.
I just want to jump in and say it's so exciting to hear you talk about this, Dora, because in many ways when we think about the safety net from a research standpoint, I so badly want to believe payment will lead to access, right? If I just paid more, then the patients can get through the door. But just as Carla Denise was saying, and what she's saying, of course, is borne out in the evidence with fee bumps that were part of the ACA that tried to increase access for dual eligible patients, those who are enrolled in Medicare and Medicaid. I was so hopeful that would, lead to these really great improvements in access, but the data are pretty mixed on it. From rigorous studies, we don't see big bumps in primary care access. Same thing with the global budget data so far. What we have from Maryland in terms of the global budget demonstration mostly comes from 2018, where they compare control and participant hospitals. And we don't find, at least I think what the evidence shows is we don't see big changes in healthcare utilization, no big bumps in primary care access, and not much of the cost savings that we, of course, all want to achieve at some broad scale. And so in my mind, it's always payment plus because of all of those, voltage drops that Carla Denise mentioned. It's not just about paying for the service, it's making sure that the patient has everything they need to get through the door. So it's just exciting to hear how CMMI is thinking about this so creatively.
So I want to just shift gears a little bit and ask you all about the role of safety nets in addressing social needs. And so we've been talking a lot about safety net providers in increasing access, hopefully, to health care delivery through clinics and hospitals and health systems. Yet many people who are enrolled in Medicaid and CHIP also receive other assistance from other social aid programs, including food assistance and housing assistance. And there's general consensus that we have to address these social needs to improve people's health and population health. But I think there is an open question about what the role of safety net providers is in playing that role. And so I wonder if each of you want to comment on what the appropriate role is for healthcare and safety net providers in addressing social needs for each patient that they see. Who wants to start?
I'm happy to try to kick it off. This is a critically important question, and maybe I'll just start with a little bit of personal experience on this. So when I served as Chief Population Health Officer at New York City Health and Hospitals, which is the largest safety net system in the country. I'm proud of having started the first social determinants of health team there that was dedicated to addressing our patients' social needs. We thought hard about integrating social needs screening into, routine operational workflows, and then setting up, the right, essentially referral pathways and, resource connections based on that social needs screening. And so I do think that there is, a major role that safety net systems have to play, particularly for, the patients that they serve, that are part of, the population that they consider themselves accountable for. With that said, there's a boiling the ocean problem here, right? And knowing how far one can and should go, given the resource constraints that exist, and given the fact that much of what actually needs to be done, the actions that need to be taken lie outside of the realm of the healthcare system, and really require better resourcing and empowerment for community-based organizations and social service agencies that really have the expertise, and more importantly for our patients, the actual resources to actually meet those social needs. So I think that's the most important piece of the conversation, is knowing where the right balance is, to not stick our heads in the sand, to acknowledge what our patients' social needs are, but then having the humility, really is how I think about it, to know when to pass the baton. So two other just quick points that I'll make. One is that, beyond safety net systems, there's a particular role that public systems like health and hospitals have to play, because, we're all under the auspices of New York City government. And that means that we have the ability to partner with the Homeless Services, agency, with the Department of Education, the Department of Transportation. And so it's public systems sort of within the rubric of safety net systems, where I think you've already seen a lot of innovation, and where, there are, I think, some more promising approaches that can be evolved. And then the second point is just to acknowledge that even as we talk about safety net systems here, we have to acknowledge all of the ways in which the broader healthcare ecosystem is making this harder every day, because of the way in which healthcare is cannibalizing our, education budgets and everything else that we talk about when we talk about the social determinants of health. And so, in some ways, people who are working on healthcare costs and some of the solutions to rein in healthcare costs, that might actually be the most important way for those in healthcare to contribute to addressing the social needs, and not exacerbating, the income inequality and all of the other things that that cause those social needs in the first place.
So I was scared to chime in, Dave, because I have a very similar perspective, and it's not very highly favored. I think one of the most eye-opening experiences I had was when I worked in a government agency and discovered the number or the percentage of employees who were eligible for Medicaid. And then I went and worked for a private agency, hospital system, and discovered the number and the percentage of people who showed up to work every single day who were eligible for Medicaid. And I thought to myself, all these years, I thought the people that we were putting in the safety net were people who had no capacity. And it's actually true. They don't have the capacity to pay for their healthcare expenses, because the amount of money they make on their job doesn't allow for it. The coverage that's provided by their employer isn't sufficient, if it exists at all. And they don't have the time to care for themselves to prevent themselves from being sick in the first place because they're so busy working. So I'm working 3 jobs, finding time to go to the doctor doesn't happen until I end up in the emergency room. And these are the people who are in the safety net. There's this misconception that the safety net is protecting those who need to be protected, but it's actually catching the people who shouldn't be falling in the first place. So to your point, I think, Rachel, part of what we need to do, oh, Dora, you are a genius. This multi-tiered alignment needs to be used as a mantra, I think, for addressing those social determinants of health that not only afflict people who are falling through the cracks, but even people who may have means and have insurance, but are suffering from the weathering and the stress of institutional racism and discrimination. The other thing that's been distressing in my career is that this perception that there's poor and Black are a synonym, uneducated and brown are a synonym. Just look at the 4 of us on this call. We are exceptionally educated, but equitably at risk for poor health outcomes, mental health outcomes, because of the stress and the weathering we suffer on a daily basis as a result of racism. So the social determinants of health has taken on this meaning that people assume only refers to the other. But every single one of us on this call is affected by the social, economic, and political circumstances of our everyday lives. So we absolutely need to have a reimagining of the safety net that actually has that multi-tiered approach so that we have enough resources invested in creating a floor. I think my goal in life is for the safety net to go away and for there to actually be a foundation with no holes in it that ensures every single person can be protected and treated, and their health can be maintained with the resources that we make available that are being overspent in inefficient ways. And if we stopped robbing education system and stopped robbing, right, our environmental systems that are here to protect our health, maybe we'd have enough money to cover the healthcare costs because we wouldn't need so much care.
Thanks, Carla Denise. Go ahead, Paula.
I just want to tattoo everything that Carla Denise and Dave said on my forehead. And then also just add that this point about healthcare contributing to structural inequities as an industry, I think, is one that we can design policy around for mitigation. So for example, one of the places where policy tries to get hospitals to do the right thing is around things like community benefit spending, right? This has been a part of hospitals' nonprofit status for as long as I can certainly remember. Yet there's very little teeth behind what community benefit spending means. And part of that is because communities are different and we want to be flexible so that we meet the needs in different places. But perhaps there's also an opportunity there to align some of what we're talking about today with goals of what community benefit spending should be. So if we know that healthcare makes up the fastest growing sector of the low wage workforce, maybe we can tie wage policies from hospitals and health industries toward part of what they count as community benefit spending. That in and of itself feels like it would go much further as a social determinant of health investment from a hospital or a health system, as opposed to that health system like investing in housing and saying this is how we're going to fix the homelessness problem in America. You know, it feels like there are these really important and natural opportunities to align policy with what I think, you know, the call is now coming from inside of the house. All of us are sort of within this industry and we see this as a problem. And so I do think there's a really valuable opportunity here to sort of get policy to match that up.
Do you want to go ahead? Do you want to weigh in, Dora?
I just want to say brilliant, Paula, brilliant.
I certainly do would give a +1 to that. I just wanted to mention the CMS Innovation Center. We are increasingly focusing on how do we address social needs. We have one model that recently terminated the Accountable Health Communities model. And it's always a bit amusing for me when we launched it back in 2016 and 2017, we started talking about it. It was like revolutionary, the first time ever. CMS is the premier health institution, the largest payer actually taking on this challenge. And now 5 years later, when the model is complete, it's almost like an expectation that, of course, we would be wanting to learn if our beneficiaries have social needs, thinking about how we can refer and help them navigate, which I certainly appreciate. The challenge, though, for us is how do we sustain this over the long term? And some of our colleagues are thinking about what are the measures for screening? How can we better embed? What are the flexibilities to help pay? Perhaps even most importantly, partnership. How do we work more closely with our colleagues in the Administration for Community Living, for example, who have the Area Agency on Aging and block grants that could support some of this work? Or how do we work more closely with our colleagues, especially at CDC, who have perhaps the longest experience and expertise thinking about these issues? So I'm pretty excited about where the direction is the CMS going. I think one of the challenges for us is moving beyond the individual beneficiary level, more upstream to address social determinants of health at the core, the root cause. And that will require certainly ongoing partnerships outside of CMS with those agencies that have more accountability, more resources, and more knowledge about how to take on these challenges. So I'm pretty excited, though, in terms of the progress we've made and where I anticipate that we'll be going. I also, just really quickly, +1, Paula, the community benefits. Certainly not making any news today, but this is thinking about community benefits as part of our strategy is a very active area of discussion, and I'm hopeful that we'll be able to nudge this issue forward in more progressive ways as well.
All right, so we have 2 minutes left. I want to ask you each to answer one question really briefly. You each get less than 30 seconds. So the question is this. The current safety net is often described as a patchwork system, and we've discussed a few opportunities today to make it better. Without giving you the opportunity to blow it up and start all over again, if you could do one thing you think could really make a meaningful difference in the short term, what would that be? Dave, do you want to go first? Oh, Dora unmuted, so she may have just saved you. Dora, do you want to go?
Oh, sure. One area that CMS is has not focused on, but if we were really able to bridge our statutory and regulatory differences so we could braid and blend funds at the state and local level, I think that would be hugely helpful in taking this on in a major way.
Great, thanks.
Mine is a nice segue from Dora's, actually, and it's the notion that, we often think about the safety net as operating within resource poor settings. And of course, there is some truth to that, but it's a shift in mindset to think also about the safety net as being so tremendously asset rich when it comes to taking advantage of those braided and blended funds to link across healthcare, public health, and social services. And for us to really lift that up as a model, not just for the safety net, but for healthcare writ large.
I can jump in and just sort of echo the same theme, which is that I think there are a lot of resources out there that are just unfortunately being mistargeted. And I think that there are many opportunities to realign the targeting of these really well-intended programs like the Dish Payment Program, like the 340B program, in ways that get them closer to where their targets originally were set by statute. I think there's a lot of potential there.
I'm going to say ditto. And I thought Paula's comment about what counts as community benefit and really thinking critically about that so that hospitals and health systems have the opportunity to invest in themselves in ways that enable them to improve the health of their workforce as well as the community they serve.
Great. Well, thank you all for joining us for this conversation. It's really a very rich conversation. I wish we had more time to get in depth on many of the issues that have come up today. But I appreciate you all taking the time to spend an hour with us and sharing your expertise and your passion about this topic. I hope that you will join us in the new year for our next panel, which will be on unpacking consolidation in healthcare. Until then, I hope you all stay well, and thanks for joining us today.